Very much. My name is Glenn Matfin. I'm Professor of Medicine at MBRU in Dubai, and it's my great pleasure to interact with you in Bahrain as part of the BDER 2022 meeting, and I wish everybody great success. My topic today is time in range in diabetes management, which is a relatively new field of diabetes. So hopefully you will learn something and it will stimulate you to explore more deeper. I don't have any disclaimers in relation to this particular presentation. Let's just remind you why we treat diabetes. So the most important reason why we treat glucose levels is because we don't want any acute decompensation like DKA or HHS, for example. And also we don't want microvascular complications because we know from the landmark study in the field of type 1 diabetes, the DCCT study, and also the study in type 2 diabetes, the UK-PDS, that as the glucose levels go up on this study measured by HbA1c, glycosylated hemoglobin, we get increased risk of microvascular complications, retinopathy, nephropathy, and neuropathy. And what we learned from those intensive glucose control studies, that as you decrease glucose from any level to whatever level, you actually get a very robust reduction in microvascular complications. What we also learned, which was interesting, is that as you treat these people very aggressively shortly after diagnosis, you get long-standing benefits with respect to reducing complications. And that's what we call metabolic memory or legacy effect. And for those two studies, that has gone on for 10, 15, 20 years or more. So it's very important to treat people aggressively but safely right from diagnosis if you can. Now, those landmark studies led to standards of care that we all continue to adhere to. That's the theory. But unfortunately, most of our patients with diabetes are managed under tricky situations and/or by primary care, who have got a million other things to focus on. So getting people to these targets, and here we've got glucose levels and HbA1c respectively, is really quite difficult. We also know that you should individualize these goals. So these goals are not one size fits all, but it depends on the circumstances. If you're older and frail, maybe your life expectancy is short, maybe you've got significant comorbidities like cardiovascular disease, then the A1C may be acceptable at 8.5. I've also said that, if you're at particular risk for hypoglycemia, or you may have hypoglycemia unawareness, then again, you might modify the goals at least temporarily until you get those situations in check. I've also stated that, if we can get people in good glycemic control from the get-go, that has long-term benefits for our patient, legacy effect, metabolic memory. So that's the standards of care. And we've had them for, decades now. But what is the reality? And I was an investigator in the T1D Exchange Clinic Registry. And this was looking at people with type 1 diabetes, 27,000 participants from, youth all the way through to elderly adults. And you can see that the HbA1c, the most recent one, as an exemplar, was really all over the place. So, for example, as you were younger, on the right-hand side, very few, less than 25% of people, for example, less than 5, were getting an A1C even below 7.5, never mind 7 or lower. And as you go through adolescent, young adulthood, your A1C on average was kind of 9%. in that specific population. And it took several decades for it to kind of settle down and get in a reasonable place. So that's the big challenge. And these were good diabetes centers. What about type 2 diabetes? And this is from a New England Journal publication last year from the NHANES observational study. And you can see in blue on this particular cartoon that how many people achieved an A1C less than 7, which I've already said is the standard of care, and it's about 50% in the last cohort, which was 2015 to 2018. And about 75% got less than 8. So this is really not a great place to be, because we've got many wonderful new medications, GLP-1 receptor agonists, SGLT2 agents, new types of insulin. So really, we should be doing better. So what is it that is hindering us? Well, one of the major things is hypoglycemia. So this has always been the Achilles heel of diabetes treatment, right from 100 years ago when we first got insulin. And how do we define hypoglycemia? We can define it as level 1, which is less than 70 milligram per deciliter, down to 54 milligrams per deciliter. Level 2 is less than 54, and level 3 is severe hypoglycemia, which is when we usually need the assistance of a third party to administer rescue therapy. Level 2 and level 3 are the most important to a degree because they're associated with real clinical sequelae, increased morbidity and increased mortality. Now let's go back to that type 1D exchange study, just to get an idea of how common severe hypoglycemia is. And don't forget, when you've got really young kids, you can't always define hypoglycemia very easily. Maybe you haven't captured that blood glucose level, which shows that it's less than 70 or less than 54. So they use some pretty hard outcomes in this study, like loss of consciousness or seizures. So these are probably underrepresenting, people who may need help. But you can see that the numbers are pretty frightening. So in a given 12-month period, how many people had severe hypo, which was defined as seizure or loss of consciousness? And you can see that if you're over 50, for example, on the far right-hand side, 14% had seizure or loss of consciousness due to hypoglycemia. And on the right-hand side of the screen, you can see if you're over 65, for example, and you've had diabetes for more than 40 years, you have a 20% risk of having a seizure or coma due to hypoglycemia. So this is a very common problem and is really limiting how well we manage our patients. Let's go back to where we are at the moment. We've talked about blood glucose monitoring, and A1C measurement have been the standard practice that we've had for the last few decades. But A1C has got limitations. It reflects the last 2 to 3 months, which under certain circumstances like pregnancy, which usually lasts 9 months, that means that maybe you only get 4 or 5 representative A1C measurements within that 9-month gestation. Other times, if you've got a problem with the red blood cell, because this is glycosylated hemoglobin, then again, you may get false measurements with respect to the concordance with the true glucose levels. And obviously, if you've got anemia, hemoglobinopathies, that would be somewhere where the A1C maybe isn't truly representative. You've got some discordance there or glycemic gap. Ethnic differences. Now, clearly, ethnicity is a very hot discussion point at the moment. But there are some differences there, and some of them are physiological. So the red blood cell and hemoglobin will bind more tightly to glucose. So that falsely elevates, if you will, the A1C. But these people also have a lot of issues with discrimination and lack of inclusiveness and access to healthcare. So sometimes the A1C elevation is truly higher than compared to other ethnicities, for example. And then the A1C itself, because it's replicating really the last 3 months of ambient glucose level, it doesn't give you any kind of minute by minute, day by day, or even week by week kind of indicator of whether you've had glycemic variability, what the postprandial glucose levels are, or whether you've had lots of episodes of hypoglycemia, for example. So there are limitations with respect to the A1C. And that's really taking us into a new era, which is using CGM intermittently or kind of continuously, real time, for our patients with both type 1 and type 2 diabetes, but also people with gestational diabetes and other circumstances. And what we would capture from the CGM, there are many different things which I'll focus on, but the most important are the time in range and also the glucose management indicator, which really gives a reflection, which is a truer reflection of your individual glucose levels. But now it's over the last 2 to 4 weeks, as opposed to the last 2 to 3 months. And that's very similar to the A1C. Just to remind us that CGM is measuring glucose levels in the interstitial fluid. So there is a little lag there from the blood levels, but generally it's a very robust marker of the glucose levels generally. And we can monitor the glucose levels using a smartphone, for example, or some other device which can scan the information so that the patient and or provider or carer can see the ambient levels. And we can have personal use CGM. I've just alluded to the fact that you've got real-time CGM, and then you've got so-called intermittently scanned CGM. This is what we call flash glucose monitoring. And then we've also got professional use. So this is where we're using the CGM generally in a blinded fashion, so the patient won't see it real time. And the important thing here is to record the CGM for the last 7 to 14 days and then evaluate that data. And hopefully that will provide some useful insights into the current treatment regimen and whether any changes are needed. I've talked about the ADA guidelines. We'll go back to the ADA. Let's just move towards the ACE 2021 guideline about new technologies in diabetes management. And they're really embracing CGM because it will give us some nice glycemic targets, some of which are new, and they have been proven to ultimately lead to decreases in acute complications, hypoglycemia being a prime one, but also DKA and HHS potentially, and also chronic microvascular complications. And when we look at the CGM data, it will enable people like you and our patients to really work collaboratively to identify problem areas, maybe realign some achievable goals instead of this kind of one size fits all, so be more patient-centered, if you will, more individualized, and then think about where other therapies may be more relevant. And what they concluded was that we really need to represent that data, and there's going to be lots of it. You're going to be measuring glucose levels potentially every 2 to 5 minutes, depending on what device that we use. That's a lot of data. And we need to capture that and analyze it in simple ways because we're all busy people. And they recommend using the ambulatory glucose profile. Now let's go back to the ADA 2022. And they also recommend the AGP as being the standard way of representing all this glucose data from the last 7 to 14 or even longer CGM glucose measurements. And they reiterated that the time in range is really important because it has been proven, for example, looking at the DCCT data that I've already discussed with you, that decreasing some of these metrics, including increasing time in range, will lead to decreased risk of microvascular complications. But also, it's not just the time in range, but it's the time below range, the hypoglycemic range, and the time above range, which are important, the hyperglycemic range, where we don't want to keep people too long because that can translate into acute decompensation and or increased risk of microvascular complications. Now, in 2013, we had 2 white papers. I was the medical director at the WHO Collaborating Center, the International Diabetes Center. And they actually really have worked up the AGP tremendously well. And now it's the standard printout, as I've already mentioned, for various CGM devices, but also can be used for SMBG, self-monitoring of blood glucose. And Roger Mazzi, he's in the kind of red box there. He first described the AGP in 1987 when I first graduated. So he was working on this for the longest time. And it's nice to see that this important piece of work has come to fruition. And an earlier example of this is on the right-hand side. So the AGP and the IDC version is the Capture AGP, captures various glucose metrics as a visual display, and then as a daily view calendar if you want to specifically look at given days of the week over a month period. This is one example. Early on, when gelaglutide first came out in 2014 timeframe or something like that. So not only is it important to capture glucose monitoring more effectively, but in order to really transform diabetes care, we've got to have the effective tools to change what we find. So finding, new drugs like gelaglutide or semaglutide or, tirzepatide when it comes to market eventually is really important because it will enable us to take what we're finding with respect to these patterns and hopefully modify them accordingly. So what you can see here is a middle-aged man, 15-year history of type 2, he's obese, his A1C is not in a great place, got fasting hyperglycemia, he's already on a lot of treatments, metformin, SGLT2, sulfonylurea, and insulin glargine, and his A1C is almost 10%. His glucose is out of range most of the time. In fact, he's only 13% of the time in range, and in range for this readout was between 70 milligrams and 180, which is kind of 4 to 10 millimoles per liter. And then what happened if you add gelaglutide, stop the glycoside, you can see that now, 3 months later, his A1C is 7%. His time in range is now 77%, which is tremendous. His glargine dose has decreased. He's had no hypoglycemia. and has lost 5 kg. So what does the AGP look like in the 2022 timeframe? Well, this is just one part of the kind of snapshot, if you will. And in the top right-hand corner, and I put number 1 because this is where you should focus initially. Who is the patient? How long have they been wearing the CGM device? And how long has it been active? So you generally want it more than 10 days out of 14, and you want to be wearing it, more than 70% of the time, at least. Then you're going to look at the glucose metrics. What is the average glucose over that time frame? What is the kind of A1C equivalent, if you will, the GMI? What is the glucose variability? Because that can, potentially lead to problems in its own right with increased hypo, increased complications. And you want it less than 36% of the time there. Then you focus on the time in range, time above range, and time below range. You really want to start with the time below range. We don't want our patients to have hypoglycemia. Once you've dealt with that, then you can think about time in range and time above range. And these goals are for type 1 and type 2 diabetes. Then we look at the glycemic profile, if you will. This is the true AGP, really. And you can see here that the median is in the middle. That's 50% of the time. And then we've got various percentiles there, 25th, 75th. And then below that, we've got respectively 5th and 95th at the top. And it gives us a good idea about different parts of the day. So midnight, overnight, from breakfast to lunch, from lunch to evening meal, and then evening meal through to midnight. And what you can see in red really is grabbing your attention, and that's the time below range. And you can see that not only have you got the 5th percentile below there, but you've got pretty much the 25th percentile. So 25% of your time potentially is below that range. And what you really want to be looking at in clinical practice is is the 10th percentile in or approaching the hypoglycemic range. That can be really useful. And then you go to the daily profiles, and you can see here, you may be doing exercise on a given day of the week, or having a dietary treat like eating a pizza, for example, or maybe your weekend exists completely differently from your working week. So these can be useful under those circumstances. Okay, now again, we've got to individualize all these different measurements. I've already discussed that all persons should be wearing the device, and that the mean glucose, GMI, and glycemic variability can either be individualized, or we have a specific cutoff, like less than 36% of the time, for example, for glycemic variability. And these are the levels that generally we would be looking for. So time in range, we want more than 70% of the time. 70% time in range correlates to an A1C of about 7%. We're always focused on time below range. So less than 70, level 1, less than 54 is level 2. And we want people really 1% of the time or less in level 2 or below. And that translates into less than 15 minutes per day. And then time above range, you can see the various thresholds. And what are we trying to do? Ultimately, we want to increase time in range and decrease time below range. And it's interesting to know that every 5% increase in time in range is associated with clinically significant benefits. And also, every 10% increase in time in range corresponds to a decrease in A1C of about 0.5%. Other populations, we may change the time in range range. So for example, in pregnancy, it may be 63 to 140 instead of 70 to 180. Similarly, in older people who are more frail and maybe got other stuff going on, comorbidities, then again, we may be more gentle in trying to get them in that specific 70 to 180. So instead of more than 70, we might want them, more than 50%, for example. But what we don't want for people who are elderly and frail, we don't want to overdo it, because are they really going to benefit from, glucose reduction translating into decreased microvascular complications if, for example, they're 70 and got dementia? So these people, actually, hypoglycemia is a bigger problem. And you can see that now, instead of like 5% time below range, we've got literally 1% time below range as the goal. And if you like, pictures, then this just tells you exactly the same thing, but in an image as opposed to just numbers. I've already shared with you how we might look at it. First and foremost, what is the quality of the data after being wearing the device? How long have they been wearing it? Then you focus on the overall glycemic states, the GMI, average glucose, glycemic variability. Then you look at the time in range, time below range, time above range. Always focus on the hypoglycemia first. If that's a problem, deal with that. If it's not, then think about time in range and time above range. And then what we're looking at is really the daily profiles. Is there something that is different on a weekend compared to the week? And within a given day, that ambulatory glucose profile, where are the problems? Is it overnight, after the morning meal, after the midday meal, or after the evening meal? And then once we summarize all those findings, we can then have that shared decision-making with our patient and change the treatment regimen as needed. And to do that effectively, we need to know what treatment they're on, clearly, but also what sort of food regimen may be related to that specific time of glycemic change, and maybe what impact physical activity had. This is my last slide. In order to do this effectively, we probably need to have a good multidisciplinary team who know what they're doing and are familiar with all these different technologies. We've got to be able to educate our patients and other clinicians in how to utilize these tools. And we need to be able to understand these reporting printouts, if you will, the AGP and time in range, in order to make appropriate treatment decisions. And I thank you for your time, and I'm happy to take any questions. Thank you very much.